You're ready with your slide. Good afternoon and welcome to the Pressure Ulcer Prevention webinar for the Intermountain-led Hospital Engagement Network. We're glad that you could join us, and we have a very exciting session planned for you. Next slide, please. A couple of reminders to get started. First, we've got our next webinar in September will be dedicated to adverse drug events, and the date is still being finalized on that. We'll let you know as soon as possible. And then we've got a couple of affinity group calls coming up that I'd like to remind you about. On August 9th, this Thursday at 2 p.m. Mountain Time, we'll be joined by Terry Keene and other subject matter experts on early induction. On the 11th at 11 a.m. Mountain Time, we'll be talking about patient falls and injuries. And then on the 19th at 1 p.m. Mountain Time, there'll be a follow-up call on reducing readmission. So please let those in your organizations who are working on these topics know about these affinity calls. It's an excellent opportunity to come together with your questions and have discourse, not just with the subject matter experts, but others in participating pledged hospitals across our network so that we can learn from each other. You will be getting an email from Jason Scott this week on these topic-specific affinity calls. We asked in the second quarterly survey for you to identify those people that should be notified on the affinity calls. And what we'd like to probe you on in advance are, do you have specific issues or topics related to the patient safety area that we would want to be prepared to cover on that call? So if you'd like some specific discussion around what you're struggling with or what you've learned as a success story, please let us know in response to Jason's email. Next slide, please. We also want to let you know that we sent out the first Hospital Engagement Network newsletter, and this was in direct response to comments from the second quarterly survey that was sent in June, where people were saying, you know, it's not always clear to folks what the goals of the Hospital Engagement Network are, so they're clearly listed and identified here. We also took an opportunity on the reverse side of this to highlight a success story. So there's a really great success story on this, some highlights from the blog. This is a tool that you can use in your own organization to send out to interested persons, and not just frontline workers working in these areas, but your leadership to keep them informed and involved of the progress that you're making and the work that you're doing in this particular network. At the bottom of the newsletter, there's a specific article that deals with the timing and the strategy around beginning the measurement process. In the quarterly survey, we asked you for the name and contact information for your measures person, and we're beginning to make those contacts with those individuals now so that we can begin using our system to not only collect the data, but to provide meaningful feedback to you, and also in a de-identified way, using the aggregated measure specification, which is again talked about in this brief article, to report as we're required to do to CMS. Next slide, please. So without further ado, I don't want to take up a lot of time, but I do always want to remind you that if you need technical assistance, if you have questions, you can always email us at admin@henlearner.org, and you usually get a response within 24 hours. And secondarily, please begin to feel like our website is a resource site for you. We've put enduring materials there, resources, links, a variety of different kinds of information, and that can be found at www.henlearner.org. So next slide, please. I'll turn it over to our lead subject matter expert, Marlyn Conti, who will introduce her team to you. Thank you. Marlyn.
Welcome. Can everybody hear me okay? We don't get any comments. All right, thank you. Next slide, please. So this is the CME statement regarding getting some contact hours. And if you complete this, there will be a little survey at the end of the webinar, and I believe you'll get your CEUs after that. Next slide. Just a little bit about myself. I work in the Quality and Patient Safety Department in the Central Office for Intermountain Healthcare. And my role is mostly the patient safety initiatives, national patient safety goals, and reportable events. We have 22 acute care hospitals. 4 of those are larger tertiary care centers, and 7 of them are rural. So all of our solutions and processes have to be modified to fit large scale and small scale and be usable at all different types of facilities. So I think we've learned a few lessons. Next slide. I'll let Baylor folks introduce themselves. Do you want me to introduce them?
Hi, this is Gina Garinger. Can y'all hear me?
Yes.
Yes.
Thank you. This is Gina Garinger with the Baylor Healthcare System. Baylor Healthcare System is located in North Texas. We are a nonprofit organization. We have 26 hospitals and about 500 ambulatory physicians that are part of the Baylor network. With me today, I have Monica Spencer. She is the nurse practitioner for the Comprehensive Wound Care Center at Baylor University Medical Center in Dallas. That is our largest facility. It's also a teaching facility. We have Brenda Blain on the phone. She is the Vice President and Chief Nursing Officer and Chief Operating Officer for Baylor Medical Center at Irving. We have Polly Joe with us. Polly Joe is the Program Manager for Wound Management at Baylor All Saints in Fort Worth. And Marygrace Leveille. She is a nurse scientist for Baylor University Medical Center in Dallas for the corporate office of RCNO.
Thank you, Gina. Okay, so the objectives for our presentation today are similar to ones for some of the other ones and for the fall program as well. We want to help you identify components of an effective pressure ulcer prevention program. And at the end of it, you should be able to list at least 2 interventions that we've mentioned that you could apply at your own facilities. And then begin to be prepared to submit your measures of success. We will be listing the ones that we have submitted as recommended measures and have a little discussion on that. Next slide. I wanted to start out with why we're talking about pressure ulcers and why it is one of the very first initiatives that we're working on with our hospital engagement network. This is the CMS data from some baseline that was reported in a recent National Content Developer Weekly webinar they had on June 4th. And as you can see, pressure ulcers are number 2 in terms of hospital-acquired conditions that CMS and all of the other agencies are interested in. So there's big reason to be looking at it. They're also very debilitating once you get a stage 3 or 4 pressure ulcer. It takes a significant amount of work and dollars to get it fixed, or maybe not ever get it fixed. Next slide. So our outline for the content is some tools around getting started, things that you would need to do in this organization, things that we've done both as Baylor and Intermountain in the area of working harder and performance improvement, and then some things that we're playing with right now in being ahead of the curve a little bit, and then, of course, the measurement pieces. Again, this is the same structure that we're asking all of the HEN webinars that we're doing for Intermountain. Next slide. So at Intermountain, this is just a sort of schematic of how we think you need to approach getting started if you've not already done so. And I did look at some of the HEN assessment information that was collected initially, and about 30 to 40% of the hospital participants have said, yeah, they're already started, they're in the working harder stage or the ahead of the curve stage. But there's still some others that are still trying to put their program together, so this would be important for them. First thing is probably nothing new. It really needs to be an organizational priority. This can't just be something that is owned by the wound clinic, nursing services, or the quality department. It has to be owned from the top-down level, senior leadership, chief nursing officers, and all of the other disciplines involved. The second one is that you need to have a standard risk assessment methodology. And for Intermountain, and I know for Baylor and most of the people that I'm familiar with, or facilities that I'm familiar with, we use the Barbara Braden risk assessment tool, and we do the Braden scoring as part of the nursing assessment process. Then we developed monitoring systems in terms of collecting data, because we all know if you don't measure it, you can't manage it, and you certainly can't improve. But you have to have that set up early on if you don't already have it in place. And we found at Intermountain, as well as you'll see in the literature and some of the references, that the appointing of champions, people who have local ownership, have clinical expertise, have their foot in the door, have their money in the game, so to speak, are much more effective than just making it part of the quality department or the wound group. So for all of our facilities, we have a designated pressure ulcer champion, and all of our clinical nursing units, there's also a designated pressure ulcer champion. And some people call them different names, but they're essentially a clinical specialist at that facility who takes ownership and pride and facilitates the local communication and getting the reporting and working on our education products and our tools and other sorts of resources. And one of the biggest things that we've seen in terms of a barrier for Intermountain, and well, I think we've seen in the literature as well, everybody does a good job of doing the assessment, but we all don't always do as good a job implementing the specific interventions that will prevent the pressure ulcers based on the specific risk assessment. And then, of course, you have to have a robust Plan, Do, Study, Act process in place, or a performance improvement process in place. Next slide. So there are several nationally available tools, starter kits, tool kits, et cetera. These are just a few. These will be on the HEN Learner site if they're not already there. I think a few of these are already there. And then if you find some as facilities, please go ahead and send them to us as well, and we'll get them out there. Pressure ulcer is one of those areas. It's actually similar to falls and adverse drug events where there's tons of information that's out there. What your challenge is as an organization is to distill it and find the right structure and mix and communication plan for your organization. Next slide. So how Baylor got started. Gina, are you going to take over here?
This is Polly. And,
hey, Polly.
And some of the things that we did at the system level at Baylor was very similar to what Intermountain was talking about, in that we wanted to develop a system policy so that we were all working together from the very top. And then we again looked at the Braden scale. We felt that the Braden scale was one of the most important tools in looking at the risk for our patients. And then a committee to standardize the interventions and preventions, and the committee's been together for about a year now working on all of those things. And then what we also wanted to do, once we got all those things in place, then we wanted to go back and to be able to take a look at our hospital-acquired pressure ulcers with root cause analysis to them. Now that we have all these things in place, if we've got one, what's causing it, that we can go back then and look at those specifics. And then, of course, you have to continue the education. You have to make sure that once you've educated everyone at the start, that you continue that education process throughout. And then posters are an excellent way. Anytime something new comes out, and you're going to see a couple of slides that follow up with some posters that we've used. And then you want to look at whether you're on an EMR system or whether you're using paper charts, some way to make sure that you're alerting staff on what you've got, physicians that need to sign orders, and a plan. So whether it's a paper chart or an EMR chart, you need to make sure you've got something that's available to continue that process.
Next slide.
Thank you. So back to Marlyn at Intermountain. This is just sort of a schematic of the structure that we've set in place. We have a central office team that's the wound and skin team, and I sit on that group as the champion for pressure ulcers and the link with quality and patient safety. The central office team's main purpose is to provide support for the facilities and the champions in the facilities. And we work on and standardize all of our education tools, assessment tools, both hard copy and electronic, other tools in terms of education fact sheets and posters and signage and stickers and things like that that can go on the patient records. And, of course, standardize and promote the appropriate prevention activities and, of course, monitoring. And we have a very robust data set at Intermountain Healthcare with our pressure ulcer prevalence studies, as well as we've begun to harvest information from our electronic medical record as well for pressure ulcers. And we have data analysts in the quality department who help us with that very effectively. Next slide. This is just a screen print of what we do at Intermountain. We don't have a policy for pressure ulcer prevention. We have a collaborative practice guideline that is our protocol, and it is system-wide. It is regularly reviewed and updated based on literature and based on what we're seeing in our own events. I do root cause analyses, actually coordinate the root cause analysis team for the system. So I get to review every RCA done And one of the processes that we've been put in place a couple of years ago was if there's an RCA related to a pressure ulcer, that full root cause analysis and the action plan goes to the wound and skin team so we can share the lessons learned there and try and implement system corrections as appropriate. So this protocol has embedded in it the assessment tools, the Braden tool, what we do for patient care management. There's some education components with the links to the patient education fact sheet. There are some decision algorithms and other things. It's all embedded online and readily available for the nursing staff. And then we build our charting tools, both electronic and paper, to meet the protocols and the recommendations. Next slide. Some of the things we've done in terms of staff education. For all of our nursing staff, we have Pressure Ulcer Prevention 101 and Pressure Ulcer Assessment and Staging 101. We've split those topics into 2 computer-based training modules that are part of basic clinical orientation and the nurse residency program. And then when we update them and review them or update the content, they're reassigned to the clinical nursing staff as well. The pressure ulcer prevention is about 15 minutes long. It's a computer-based module with a little test. The assessment and staging, we found that as we were collecting data from our computerized medical record, we found that we had a little bit of inter-rater reliability. And so we built this tool to help the nursing staff better understand what a stage 1, 2, 3, 4, et cetera is. There's a little quiz with that. And we had about 3 years ago a significant event in a long 12-hour neurosurgery case. The patient ended up with a stage 4 ulcer and have since embedded and developed some skin assessment protocols within our intraoperative services and within the OR. And they have mandatory training for all the surgical settings for new hires, and then it's reassigned each year as part of their patient safety module as well. And a few years ago, we also did purchase as Intermountain a mattress that would be therapeutic as we were looking at trying to figure out what we could do that would make the most impact the quickest with our pressure ulcer prevention. We found that there's often a significant delay between the nurses feeling like this patient's at a higher risk and I need to get them on a therapeutic mattress or bed. It could be 12 to 24 hours or more before you get it there. And so we as the Wound and Skin team asked our chief nursing officers if we could just replace all the mattresses with a therapy mattress. The mattress we chose, and we did a whole RFP, worked with our supply chain folks and went out and looked at a lot of different vendors. We ended up choosing one that lets you hook a pump up to it. So you have pressure relieving for all patients, and for the patients at a little higher risk, you can hook up an air pump, which gives you then the next level of therapy for that patient as well. The next things we have are, since we did participate in the NDNQI, the American Nurses Associated Nursing Magnet Program, for a number of years, we used their data collection process and have conducted quarterly prevalence surveys. We still use their data collector training that's available on the ANA. We have permission from that organization to use it. That is embedded within Intermountain's learning network, online learning. This is only assigned, it's fairly rigorous, and there are 4 modules to it, and it can take you 1 to 2 hours. That particular training is assigned to the folks that are the champions and the data collectors at the unit level. They're the ones who do the data collection for our pressure ulcer prevalence surveys, and again, are their peer leaders on the unit. So that module is assigned to that group of folks. Then we have an online database that we manage out of the Quality and Patient Safety Department, and we just have a little data entry training, computer-based training module so that we get the data entered in correctly, and that gets assigned just to the people who've been assigned at each facility to enter the data. So we manage that as well. So those are just some of the pieces that we've done with education. And that's all part of getting started. Next slide. Working harder, this is one of the tools that we've found, and we actually built this a few years ago when we looked at a root cause analysis on a pressure ulcer. And we have a very robust electronic medical record, and it tells you what you should do, but Intermountain's care plans are still paper-based. And so we had a little bit of a disconnect between the electronic risk assessment and what the nurse said they were going to do, what actually ended up on the care plan. And so we built this little card, and it's actually loaded in our forms repository. There are 4 per page, so it's a print-on-demand form. You print it out, and you can color code it, and it goes on the CareDex. And it's linked to the Braden tool, and the nurse can check off the specific things we're doing for this specific patient based on their Braden score and their specific risk factors. We are continuing to work on actually revising our EMR. Right now we have a task force working on it, trying to build a little more logic into that, but we will still have the gap between charting and care plans. Next slide. This is an example of one of the algorithms that we've built, and this algorithm was built to help staff. You know, we have this pressure relieving mattress, but there are times when you really do need to get an additional therapy surface or a rental bed. And we were trying to, number one, standardize when we order the beds so that if the patient really needs it. We had an event where somebody had put a pressure relieving mattress on a patient that had a spinal fracture, which is a contraindication with a therapy mattress. And so we developed this decision algorithm that says the patient's Braden score is this. If the patient has a spinal injury, don't do this kinds of stuff. So, and this is embedded in, it's one of those tools that was embedded into our online protocol, as well as it's a print-on-demand 8x11 little sign you can put in patient rooms or staff rooms or wherever you need to for that. This year we've also implemented a process where when they order the specialty bed or the additional mattress or overlay, they have to go through a wound specialist who then intervenes and can talk about what really is the best surface for this patient. So they end up doing a lot of discussions with physicians as well. And that's helping us to save money as an organization on rental beds that sit and are not used or are used on patients that really don't need it. But on we're watching our pressure ulcer rate. It still continues to be fairly low as well. So this is just the one algorithm. Again, another tool as part of our working harder process. Next slide, please. Just a screen print of the Braden tool, and I really just wanted to talk to you here about the fact that it is embedded in the EMR. However, Intermountain has not always been electronic, and it's only been about 3 years since we've had it all over rural hospitals on the computer for inpatient charting. So we've had to build the same tool into the paper forms as well so that we have that redundancy built in. And the piece we're working on right now, as I said earlier, is embedding logic so that if the Braden score in nutrition is a certain number, that it will prompt them to get the nutritional assessment. So that the things are specific to the patient-specific risk factors. So we're trying to build in our working harder piece a little more of that. But just wanted you to know we had to set it up front in the electronic medical record as well. Next slide. This is our patient family education fact sheet. We have it in English, Spanish, and for pediatrics, English and Spanish as well. And it's embedded in our clinical protocol, and there's a link to it within the computer charting so the nurses can print it out at the time when it has meaning for the patients. Do you want to print it out and do your education at this point in time for your patients? But we found that the message that was getting to the patients and families had significant variation and very often depended on the expertise of the nurse who was delivering the message. So this is one of our tools that we use to standardize. Next slide. Some of the things we've been doing the last 2 to 3 years in working harder is those little care plan cards that we showed you. We have some dressing posters, equipment. When we replaced our mattresses a few years ago, we dropped our pressure ulcer rate in half, and I'll show you the graph here in a few minutes about that. But one of the things that we found we had not done is we didn't build in a routine inspection process for the mattress. Previously, mattresses were a piece of furniture, and if it broke, somebody would call housekeeping or engineering. But when the mattress is part of the bed, engineering was looking at the bed for electrical safety and did the rails go up and down, but nobody was looking at the mattresses. So we found a significant percentage of our mattresses that needed to be replaced. So we've had to embed a tool in our preventative maintenance process that flags them to physically look at the mattresses every year. And then we talked to you about the therapy beds and the decision algorithms that we've built. And this year, what we call the gatekeeper process, where they have to go through a wound specialist. Then the electronic records that support the nursing standards. We have inpatient charting tool and an outpatient charting tool. There are 2 different systems right now. And then, of course, data collection is required for the prevalence surveys and then targeted education for nursing staff. We also have a group of folks out there that are WOCNs, so wound ostomy continence nurses certified in that. We've been trying to get more of those folks and then set a partnership with our rural facilities so they can work with a wound specialist at one of the larger facilities. Slide. Baylor, this is yours?
Yes. Yes, this is Polly again with Baylor. And this slide is really shows how Intermountain and Baylor put the same processes in place, and shows, I guess, if you duplicate good things happen. Because, again, we wanted to look at executive leadership and make sure that from the top down we were really involving the right people. And so when you get the leadership involved and they're behind you, then it makes it very easy to continue the process. And then again, we put a SWAT team together, which is our skin specialist, and we began reporting our prevalences monthly to our leadership team, and then focused on individual accountability for each of the bedside nurses. And when you work at top and then work at bottom, what you get in the end is really a reduction in pressure ulcers all the way around. Next slide.
Okay, this is one of the things that we did at Intermountain. This is Marlyn again. We found that having things embedded in the protocols and on forms didn't always make it to the hands of the nurses. And so we partnered with one of our skincare vendors, and we built these posters that go in the supply rooms, and they're like 11 by 18 inches, so you can get them bigger if you want them 24 inches. So we put them in the materials rooms, the supply rooms, and it says if the skin is this is the product you use, to help drive the practice with that. It also helped us get better usage of the products we had partnered with our vendors on in terms of best practice for the skin care for those patients. And you'll notice lots of little pictures there. It says, this is the skin and this is what it looks like. This is what you need to do. We found that pictures made a big difference. Next slide. There's another poster that we did as an organization, and this one sort of takes that other concept another step further. Not just the skin care, but if you have a wound or a pressure ulcer and it looks like this is the type of drainage you can expect. These are the treatments or dressings we expect you as an organization to use based on our own internal contracts. And then the frequency of dressing changes. And this is a 2-page poster. This is page 1. On the bottom of the second page, we always put the wound care specialist direct phone number on that, so it is specific to the campus as well. So this is another way of kind of helping get the word to the staff in a way that they can use it very readily. Next slide. This is Baylor.
Hi. Yes, hi, this is Monica with Baylor. I just wanted to reinforce what Marlyn has been saying about education and accountability. I think we're pretty much in line with what Intermountain has been doing. This is an example of one of our many teaching posters. We've done similar things with pictorial posters and guidelines for nursing. We've laminated them and put them on a binder ring that we've hung from our wound supply cart. We've put posters up. We're working on our My Baylor website to have a link for skin and wound care. Additionally, we've reached out to our new graduates. We have a new graduate internship that we have a block of time in, and we actually have about 8 stations where the H.E.N interns can go station to station and practice with all of our products, and we work with our vendors so that they man those, so we're not, using up our man hours. It's all their supplies, their products with our system approval. We've also brought in our techs, which has been very helpful for prevention, because our techs do a lot of our bathing and prevention and a lot of the skin prevention type things. We've added our education into our annual competencies, as well as coming up with similar flow diagrams and posters. So really just what we found with education is reinforcing it. We'll have a first pass where we catch as many people as we can, and then we're finding maybe quarterly or every 6 months reviewing things again with the nursing staff, and also bringing in just a multi-pronged approach with our educators, our advanced practice nurses, our managers, supervisors, our executive leadership, and our physicians, including everybody in these measures over time, is kind of making it familiar and having some success.
Next slide.
Okay. Now we're going to talk a little bit about measurement and some of the things that we've done at Intermountain. This is just an annotated process control chart that our data analyst prepared for me as we've been telling some stories recently, but it shows the dramatic reduction after our mattress purchase, and then with some mandatory training, the bed and surface decision algorithms, and then all the other little things we've done with care plans and posters and other educational stuff has occurred in between there. But you can see the substantial reduction in the hospital-acquired pressure ulcer rate, and this is all stages 1 and above. The next slide, please. This one just is the stage 3 and 4 over that same time period, and you can see, obviously, again, dramatic improvement. Just demonstrating that what we said earlier with the focus on leadership, committees, the champion teams, and then embedding your protocols, your education, et cetera, into your processes can get you where you need to be. The next slide. Next slide. This is a screen print of one of our web reports, and what our philosophy at Intermountain is we need to be able to roll up to the system level and drill down to the patient level whenever and wherever possible. So we have web-based reports that are on our Intranet that you can run for the system, for the region, for the hospital, for the department. And if you need patient-specific detail, we have that as well to help drive the performance improvement at the system level, the region level, local level, and even the unit level, so they have access to the appropriate information. Our data, this is from the pressure ulcer prevalence survey, so it is done once a quarter. And this has the hospital-acquired all ulcers and community-acquired all ulcers, and then, of course, the hospital-acquired 3 and 4 and community-acquired 3 and 4. We have another report that gives the same data by hospital and department level in a comparative way. We have another report that gives us a drill down to the body sites, so we know which body sites are the most frequent. And I bet you can't guess which one's the most frequent. Sacrum. And then hips, and then actually the occiput is one of our top ones on the back of the head. And then ulcers related to tubes is another big one as well. Next slide. Baylor, please.
Hi, this is Marygrace. Just wanted to present a little bit of the information about the prevalence for pressure ulcers. Interestingly enough, I think Monica had already alluded to, and so did Polly, that about a year ago we formed together a system task force that essentially combined the various leaders at the various hospitals so that we could get together and brainstorm and see how we could best reduce our HAPU. And this, if you look at this scale, we got together in like September of 2011 when our numbers were really good. So as presented in a previous slide where it says getting started, working harder, and ahead of the curve. So when we were meeting, we knew we had some issues, and we were trying to plan for anything that was going to come down the line. We didn't know that come November, December, and January that our EDs were going to get very, very busy. The patients were going to be in the ED for long periods of time, and we all know how thick the mattresses are on the ED. And additionally, when we broke down the numbers here for November, December, and January, 60 to 70% of the patients during that time were in the ICUs for an extended period of time as well. The other thing that we also looked at were patients were having surgeries and staying in surgery for a long period of time as well, supine and on those bony prominences. So one of the things that came out of our system task force is that we are going to get together with the ED, the System Council, and the OR System Council and interventional radiology to see what kind of programs we can, or processes we can put in place so that when patients are in these areas, they can also do what they can to help reduce pressures, which will then develop into, potentially develop into pressure ulcers or skin breakdown. Additionally, in November and January, when you see that spike, we had program manager from the Comprehensive Wound Center go to the ED, and it's my understanding that the mattresses were changed in the ED too. But then also we know that working harder, trying to stay ahead of the curve, there's a lot of things that we can't manipulate. Even as nurses, we like to manipulate as much as we can and try to prevent a lot of things, but We can't prevent how many patients go into the ED. We can't prevent how long a patient is in the OR. So we kind of have to deal with what we have and just educate, and try to prevent as much as possible.
Next slide.
Hi, this is Monica with Baylor again. This is an adapted version of the NDNQI quarterly audit. We found that looking at this quarterly was not giving us enough real-time feedback. So we adapted it to a monthly audit that we present to our board, and all of the managers drill down on any HAPIs that are found on their unit. And I just wanted to include this to show you, I think, as an example of what Marlyn said, of taking all this information but then making it customized for your needs and your different facilities. So we just simplified the monthly. We still get a whole team together, and every patient in the hospital is assessed, but we include other information there so we can get more real-time information. And our goal is to have no patient on this audit that we don't already know about, that hasn't already been identified as a HAPU, and we've already done a drill down. So there's no surprises. Our ultimate goal is to have no HAPUs, but when we do, we want to already know about it so that we have this monthly report to track how well we're doing, but we already know about the patients and we're already intervening. Next slide.
Baylor?
Yeah. Sorry, there's a little bit of a delay.
Okay. This is Marygrace. One of the slides that we wanted to present to you was an intervention that occurred in one of our hospitals in Irving, and it all started from a team of staff nurses who were challenged to assist to decrease their pressure ulcer rate. So essentially, it's kind of a breakdown of the interventions that the team made. They no longer use the NDNQI pressure ulcer prevalence studies as the sole method to determine pressure ulcer rate. Baylor has a system, it's called the MIDAS, and what we do is when there's a need for an improvement or for an occurrence, we enter that information into MIDAS. With pressure areas or skin breakdown, we're able to capture that information once someone has entered it into the MIDAS report. The team recommended that all inpatient nursing areas should adopt yearly competencies for identifying pressure ulcers. So again, education is very important. The team evaluated patient turning wedges and heel prevention boots. Currently, the team is working with EVS to evaluate new pillows that were introduced in 2011, and we currently monitor Braden scores of all occurring pressure ulcers to determine additional prevention methods for specific score levels. Additionally, what the hospital has also adopted is bedside reporting. So an important component of bedside reporting is essentially looking at the skin. And so you're talking nurse to nurse and saying, this is what the skin looked like for me for the last 12 hours. And so they're able to see exactly what the skin looks like. And I've been told that that has been a key factor with Irving. And I know that other Baylor hospitals have adopted the bedside reporting, and this has been really essential to reduction in pressure ulcers.
Next slide.
Okay, so now we're going to move into a little bit about the measurement period and what we're recommending. Based on the assessment that was conducted early on with our hospitals that are part of this network, and what we've seen in the literature, the most common denominator in terms of measurement that the hospitals had was some kind of quarterly pressure ulcer prevalence survey. So we're recommending that the facilities report count, numerator denominator of patients part of a prevalence survey that have hospital-acquired pressure ulcers, all stages. The next one is similar. This is the stage 3 to 4 or greater. Same data collection process, the prevalence survey, again, because that seemed to be the most common denominator. Some hospitals, as part of working ahead of the curve or working harder, have adopted, as you saw from Baylor, something that's a little more timely in terms of regular prevalence surveys or in terms of incidence data is one of the things we've been working on at Intermountain. And as I said earlier, we have been starting to do some drill down in that. We do have part of our nursing manager's dashboard is the incidence data reported directly from the EMR system. But we're finding we need to tune that system a little better. Not everybody's filling in the screens the same way. So that would be sort of moving ahead. Next slide. Some process measures that we look at Intermountain and we're kind of spotty based on the reports from the hospital assessment were compliance with completion of the admission nursing assessment. That's both the SKIN and the Braden. And Intermountain monitors as part of our medical records review system. We have a database that the Quality Patient Safety Department manages that all healthcare providers can participate in, and we've been tracking questions in there for a number of years on the completion of the initial nursing assessment and the Braden score, and then whether or not it was updated at least daily. Most of our units, particularly the ICUs, do it every shift. And then rounding to assure training, pressure relieving mattresses. Some folks have implemented patient safety rounds, and you've seen some monitoring from that. But the two that we're recommending for the system right now, the HEN network right now, are the prevalence surveys, all ulcers, and stage 3 and 4 ulcers. Stage 3 and 4 because those are hospital-acquired conditions that are part of the CMS measure. They are also considered never events by the ANA and others, and nursing never events, and they are also sentinel events, as in reportable events, and require a root cause analysis. And then there are other measures and things out there that you can see on the other websites that we've posted on the HEN Learner site, NQF and AHRQ, et cetera. Next slide. Okay, so other HEN resources, if there are articles and references that you would like us to share with the group, please send them to Jason or Amy, and we'll get those posted to the HEN Learner site. As Amy said earlier, we will be having the affinity group calls, and those will be monthly. The first pressure ulcer one will be in August, so you'll get information about that as well. I'd like to pause here for just a minute, though, and ask if there are questions from the audience that they would like to address to myself or my Baylor colleagues at this point.
Okay. First of all, we need to make a clarification on some of the affinity call dates that were listed, Amy.
Yeah, on the slide at the beginning, it stated that the affinity call was on Falls was August 11th. That's Saturday. It's actually supposed to be Friday, August 10th at 11 a.m. And that information is available on our calendar.
And we'll make sure the website calendar is updated. So the first question we've got, there's much discussion among experts as to whether bedside nurses should stage pressure ulcers, that only expert wound nurses should stage. Your thoughts?
Yeah, good question. We've actually had that question again recently at Intermountain, and it's gone to the Wounded Skin Team and Nursing Practice Council and even our medical directors. Because as you know, with the CMS hospital-acquired conditions, it only gets documented as a HAC if the physician documents it. And we actually did a retrospective audit of a full year's worth of records and found that the docs, don't take this wrong, don't know what they're talking about. And they were accurate about 25% of the time. That the people who were best in terms of staging the ulcer were the nurses. And of course, the very best would be the wound ostomy continence nurses. Well, resources is a huge issue. We do not have at Intermountain, even in our large facilities that have the continence nurses, the WOCNs, 24-hour coverage. And they are not available to make rounds on all the patients. They are manning the wound clinics, and they are called to the inpatient units for specific issues and for difficult cases. So we chose as an organization to educate our bedside nurses for the skin assessment and the staging. It's part of nursing assessment. In terms of the staging for our pressure ulcer prevalence studies, as you saw earlier, those people are identified. They're the unit champions. They get the additional training. And when they're first appointed, they get mentored by an existing champion or a wound ostomy continence nurse for their first round of data collection so that they have to pass off the wound staging at that point in time. And so that's sort of the approach we've taken to it. Our Nursing Practice Council was adamant that it's part of nursing training and should be something they're able to do as they assess their own patients. So, Baylor, do you have a different response?
I just wanted to think, this is Monica. We do it similar. The only, and I agree with what you said, the only difference is on our NDNQI quarterly audit. If a hospital-acquired pressure ulcer is identified, we do have a wound specialist go verify that, just because the stakes are so high on the HAPUs. But otherwise, we have the bedside nurse stage, we have the bedside nurse prevent, and we have our protocol that they can treat. And then if it's not working or getting worse or they have any concerns, the wound team is available as a resource. But on our quarterly audit, we do verify any HAPU that the audit team, who's been trained and mentored, identifies. It's just a second check that we've chosen to do.
Well, that helps with your inter-rater reliability.
Right, exactly. This is Polly, and everything you said at Intermountain is exactly what we do at Baylor. It's a very good process, and the fact that the physicians are the ones who are required to document what's present on admission in order for reimbursement related to CMS, it's the nurses that are going to identify those. And so we do that very well, and we let our physicians know when they are community acquired so that they can document that those are present on admission. And it works very well to do it that way. I would highly recommend that the bedside nurses be skilled in that particular identifying process.
And we developed, this is Monica again, we developed a sticker that the nurse can put in the progress note and fill out that says the patient has, whether it's present on admission or hospital acquired, and they fill it in and then the physician signs it. So that way we get our documentation in the physician's note.
Thank you. Any other questions?
Thanks. Yeah. The next one, can you address how many WOCN RNs you have? We have 12 to 16 hours per day for our 2 facilities, which is about 500 beds.
So at Intermountain, as I said earlier, we only have them at certain facilities, so they would be our large sort of flagship facilities. We don't have them in the smaller and the community hospitals at all. And that's where we've tried to set up the relationship between the large hospital and the small hospital. So at Intermountain Healthcare, which is 400 some odd beds, which is sort of our flagship tertiary care trauma 1 center, they have 3 WOCNs and a therapist who is specialized just in ulcers, but they're based in the wound clinic and the hyperbaric chamber. They do not make daily rounds. They only come to the floor as requested per consult. At McKay-D, which has about 250 beds, they have, again, a similar setup, but they have a wound clinic and a hyperbaric. They have 2 nurses on each day. One is staffing the wound clinic and one is available on the unit. They are more available at that facility for rounding, and they have one of our lower rates across the system. But I have not actually calculated a WOCN numbers per beds or per patient days or anything like that. It is a nursing resource issue.
This is Monica. At downtown Baylor, we probably have 4 to 6 wound nurses and ostomy nurses each shift. We're available Monday through Friday, 8 to 5. But we do ostomies, fistulas, VACs, and complicated wounds for our service line, but also for podiatry, plastic surgery, orthopedic surgery, trauma. So that is one of the other reasons that we really have the bedside nurse, the focus on the bedside nurse doing the pressure ulcers. But because we're out there and available doing the more complicated wounds, fistulas, ostomies, we are out and visible as a resource to our bedside nurses. So we don't see every pressure ulcer or every HAPU, but we're certainly out and about and a resource that's available. And then our outpatient clinic is staffed, and our hyperbaric clinic is staffed by a separate team of nurses within the same department. So we have pretty different focuses. We have a few people that float back and forth.
And this is Polly, and I'm also part of Baylor and at Baylor All Things, which is in Fort Worth, Texas. And we have approximately 200 to 300 beds that are we would consider wound care at risk or pressure ulcer at risk patients. And we have usually about 2 FTEs a day for the CWOCN. And I will say, though, statistically speaking, if you're looking at whether it's a good idea to have CWONs in your facility, the statistics show that if they are there, the presence of pressure or HAPUs does decrease.
Okay,
Thank you. Appreciate it. Another question?
Yes. Do you include unstageable and deep tissue injury in your data for the prevalence studies?
Yes, we do.
Yes. Yes.
Okay. Then the next question, for the hospital that is checking skin at bedside report, is that done on all patients?
So at Intermountain, we only have a few hospitals that are doing the bedside nurse-to-nurse reporting process. It's actually a system-wide nursing initiative this year. Most often it is not done at the bedside. It is a verbal handoff in a traditional nursing report process. Baylor?
It is my understanding that most of the hospitals are doing the bedside reporting and doing skin assessments on all of the units. And if they're not doing it, they're in the process of making that change to incorporating it into their report process, yes.
And the idea is that if you've got two nurses standing there, the nurse that's going to accept the patient and the nurse that's giving the patient, that's the opportunity to look at skin. So if you're doing that twice a day with two nurses, then you've got at least twice a day an opportunity to look thoroughly at skin with someone that can assist you in turning the patient. And as a side note, it's really nice if you are the outgoing nurse to know that you're passing off good skin as well as receiving. So it holds nurses very accountable.
And that also can lend towards the inter-rater reliability, that they're staging the same and they're looking at the same thing.
That's correct. Very good.
Yeah, excellent. Thank you. Any more questions?
Okay, it looks like there's no more questions. If you do have a question, you can type it into the Q&A box in the next couple minutes, or if you think of anything, always email us at admin@headlearner.org. So maybe final thoughts?
Yeah.
Hang on, there's one question here. I'm interested in any recommendations, lessons learned, and/or resources for how EHRs can best support documentation for HAPU assessment, prevention, and care. So
that sounds like a whole affinity call discussion. So if you heard the question was they're interested in how you use the EHR electronic record to support your assessments as well as your care prevention. And I guess we just have some lessons learned in Intermountain. You know, we have the assessment tools embedded, but the gap we found is between the assessment tools and the specific interventions. And so we are working on more logic for that. The other thing that we found when I inherited the pressure ulcer stuff is our electronic record was actually 5 years old and did not match our current protocol. So whatever you have in your electronic health record has got to be flexible enough that you can adapt it quickly to performance improvement whenever you make protocol changes, so that you're making sure that staff are charting correctly. And one of my sort of mantras or themes is that we need to sort of take the decision-making out of the heads of our nurses when we can force a function, when we can prompt them, when we can give them an alert or a reminder. They get so much in their little heads trying to manage everything that's going on with the patient. They're entering in, yeah, they've got the Braden score and it says the patient needs such and such, but then they get busy taking care of the catheter or the medications or whatever else is going on. So we're really looking at ways to hard code or do forcing functions that prompt the nurse and require a response, that don't let it just go on autopilot sort of stuff. Baylor, any thoughts?
Yeah, this is Monica again. We had IT involved in our system-wide council when we were standardizing our prevention and treatment based on evidence-based practice, and that was one of the impetuses of having the committee. I think we were all doing pretty good interventions, was to standardize the language so it could be embedded in our EMR, and then we brought staff nurses along to talk about, you know, what it was really like. And one of their biggest things, and we are having this built in, is to have boxes that popped up to cue them. So we broke it down into each subscale of the Braden and say moisture is the issue. If they rate low in moisture, then a pop-up box will come up with suggestions for, after they've documented their assessment, for interventions. And it'll remind them the interventions, and then they can just check them off. That was probably the biggest feedback we got from the nurses, was that they didn't have to look 2 or 3 or 4 places to document and 2 or 3 or 4 places to put their interventions, that they would put an assessment, they had a low Braden in one of the subscales, and intervention ideas would pop up and they could check them off. So we'll see. It seems like it would work. That'll be our next phase of finding out.
Excellent. Yeah, thank you. No further questions? Amy, would you like to keep the conversation going? Next slide.
Okay, our first pressure ulcer affinity group call will be held on August 28th at 1 p.m. Mountain Time. The information for that call, the call-in information, will be found on the henlearner.org calendar, so please check that. And again, we'll be sending out emails with information on that and soliciting topics as well closer to that time. And again, note that there's patient falls and our OB calls are this week as well. So check the henlearner.org for the information on that. All right, next slide.
Just the final acknowledgement. So Intermountain Healthcare has a unique skincare team. We have a nursing practice council and, of course, all of the quality folks. And our data analyst happens to be in the room with me here today, so special thanks to you as well. And Baylor folks involved there. And thank you guys for being such a wonderful tag team. And I think we're done, unless there's any further questions from the audience. Okay, send your questions through, and we will address them in the affinity call in August 28th. Thank you very much.
Thank you.
Thank you.